needs for sleep disorders and its related comorbidities patient with core competencies patient at King Fahd Specialist Hospital and all other related specialties. We know that there is a high risk patient that are undiagnosed, and it's with all related also other and pulmonary to be accepting this request. So who is operating in a sleep lab? We have a qualified sleep technologist working 24 hours. They are available, and the reporting will be to respiratory and the sleep lab director. In 2019 December, in our intranet site in the hospital. And who is eligible to have this access? It's the sleep physician, the pulmonologist. They can access the patient file and do the reporting system and interpretation after the sleep study from his office with the direct approval from our director of sleep lab. After the physician have the final interpretation of the patient, we will have the treatment plan. Treatment plan will be varying, whether it's the drug therapy, is it operational, it is cognitive therapy sometime, or surgical procedure, or the dispensing of the adequate respiratory equipment, which will be undergoing respiratory department. The dispensing will be according to special criteria. Not all the patient will have direct dispensing. Will have special criteria whether to go under social worker and charities, or the high risk patient will undergo respiratory department with the approved criteria of dispensing. What we are doing in sleep lab, what kind of test or study we are available in sleep services? We have the polysomnography study. We have the full titration study, split night study, MSLT, and adaptive ASV, which is the adaptive servo-ventilation study, and overnight pulse oximetry. Recently in 2009, we started the PDX level 2, which is the portable sleep lab study, which helped us a lot in doing the inpatient as well. We have one stand in-lab study, and the other one is a PDX, which is a portable, helped us a lot in accommodating the inpatient request, cutting the waiting list, and have the adequate outcome of this study. And recently, and not the last, during COVID, where we have a lot of patients to be discharged home for patient safety, we activated the home sleep testing. Home sleep testing is a well-known program in many regions, but here in the Eastern region, we are the first one to start this program. Where the patient come and we have a brief education about the portable. It's a portable sleep device. The patient will come in the afternoon meeting the sleep technologist. He will give the proper education about the machine, and the patient will go home hooking up this home sleep study over the night And then the benefit of this that the patient will sleep comfortably in their home instead of coming to the hospital and sleeping here. After bring back the machine the second day, and the doctor will look to the report, and we will have the interpretation and then the final diagnosis after this study. Home sleep study as well helped us a lot in discharging a lot of patients, especially during COVID, where the hospital want to have control over the infection rate and to discharge the patient as much as we can. So the patient with respiratory failure, with obstructive sleep apneas, this program helped us a lot in discharge the patient. Talking about the statistics, since the beginning, those are the numbers being run, the test run during this time. Between the full polysomnography, full in-lab study, and the titration, split night, this all being reported and according to sleep physician request, and the patient dispensing, actually, to be honest, the dispensing is never stop, and the need never stop, and we have frequently come asking for the education training for this. Actually, this process is ongoing in the hospital. The high need for sleep studies in the region increasing, actually. After we dispense this machine, it will help a lot to decrease the length of stay in the hospital. It will decrease hospital-related infections, and it is also a cost-effectiveness. Instead of the patient being in the hospital for BiPAP at the bedside and having there is a continuous education and follow-up for them, supplies or whatever they need. The weekly, every Thursday in RT. And lately, our future plan with the sleep lab services to be a well-recognized sleep center in Eastern Province, inshallah, under E1 cluster services. started a diploma program for sleep medicine training in collaboration with our colleague in academic affairs in King Fahd Specialist Hospital. Our target to be accredited with the effort being colleague, the technologist. يتتوج إن شاء الله and our goal to be a recognized center of training and clinical education for a sleep program بإذن الله. Saying this, we're promoting Saudization. We want to have a qualified sleep technologist in the near future بإذن الله, under the guidance of our administration and the support from our doctors as well. And thank you. Introducing Dr. Manal, our sleep lab director. Dr. Manal Hassan.
Assalamu alaikum. Thank you for taking care of arranging this event. And we'll talk about the current status and potentials for the sleep center. So just I would like to talk about why we are talking about the sleep and the sleep center. Because sleep-related disorders are associated with significant mortality and morbidities. Complications associated with obstructive sleep apnea include excessive daytime sleepiness, concentration difficulties, coronary artery disease, and stroke. It is estimated that around 10% of patients with congestive heart failure, they have obstructive sleep apnea, and this sleep apnea is independently associated with the development of systemic hypertension. The untreated sleep-related breathing disorder, it does result in 10-fold increase in the risk of motor vehicle accident. So it is a public health concern, and the reason for that, why also these data are from the US. So why we are concerned in the Saudi Arabia, because there was 2 previous studies in Saudi Arabia used the of every 10 Saudi women are other disorder of sleep related disease not yet estimated. So we don't know the incidence of the other sleep related breathing disorder. The estimated incidence in Eastern Province is around 1 to 1.3 million. So the burden is significant. And we are part of the healthcare provider, or the leader. We are the leader of the healthcare provider in the Eastern Province. So we have a major role in this field. Why is that? The burden is high because there is several risk factors resulting in increasing the incidence of sleep-related breathing disorder. Part of that is the male gender, the age. Our population aging started to increase, where with aging the risk, with age of more than 65 years old, the risk increase up to 70%. The risk also increase in women with post-menopause. The obesity level is increasing in our country, and also Eastern Province has high incidence of obesity, and it is estimated that obesity increases the risk of obstructive sleep apnea in up to 40%. That not only the morbid obesity itself, also the body habitus itself. Some people with a body habitus with big thick neck, or they have obese abdomen, or they have other condition associated with like polycystic ovary syndrome, which is very common in our area. It's around 1 in 4 women, they have polycystic ovary. And hypothyroidism also is very common in our area. Less rare disease like acromegaly and testosterone therapy also playing a risk factor. Less frequently nasal and facial anatomy abnormality. The smoking also, it does increase the risk of COPD, and that also increases the risk of sleep-related breathing disorder. Also family history of sleep-related breathing disorder. Alcohol, luckily we are not suffering from that much. Other risk factor related to the central sleep apnea also, which is more difficult to control, more difficult to diagnose. And that also again related to the male gender, increasing age, congestive heart failure, neurovascular disease, thyroid disease, acromegaly, chronic kidney disease, neuromuscular and neurodegenerative disease. And that make us at higher challenge because we are cardiac neuro center of excellence, so we are getting lots of referral from them, and also we are now a cardiac center of excellence, and we are getting lots of referral from them with severe central sleep apnea. So sleep surface in KFSHD has been elaborated very well by Mrs. Wafa. It went through several challenges. Since 2007, the surface was, or effort have been there for starting the surface, where it was running by portable system only. Level 2 and 3 was by previous pulmonary physician, Dr. Imtiaz, when he left. Then the neuroscience have taken over in 2014, and that has been mentioned by Mrs. Wafa, where they hired a part-time sleep physician. Then we have major challenge in 2017 when we got shut down of the 2 sleep lab unit because software were not updatable. So we sought help from dispensers. We got two demo units. In 2017, one of them pulled out by November 2018, and that put us at a critical situation by November 2018, where we have been running with a demo equipment, only single equipment with a wait time up to 6 months, and we have been like this till end of 2019 or early March, or till March 2020. Then the COVID pandemic started and everything shut off. So patient was very difficult to manage patient during the period of COVID-19 because it was not possible to do in-house sleep study as well, even with the single unit that we had. And so we were almost zero. We were zero study from March 2020 till September 2020 when we started to do the home sleep study. We started slowly. Currently, by the last few weeks, we started to pick up, and we are now doing around 12 to 15 home sleep study per week. Our expected annual around 700 home sleep study. and that will be elaborated more by Mr. Abdullah. So, just for the for the opportunity of because of the opportunity we are having our stakeholder, I want to go over the SWOT analysis for the sleep services. So our strength come from we are accessible. We are a Ministry of Health facility. Almost all Saudi are eligible to us. Our team is a part of a strength where within our team we do compete for helping patients. We don't compete against each other. It was a blessing working with respiratory therapists, especially our previous sleep lab senior, Mrs. Haya, where she was distinguished problem solver, highly supporter for the sleep center. Mr. Abdullah, his effort is flawless and his contribution is excellent. And now we have been joined by Mrs. Samah, and also she's excellent contributor. Working with her is really a blessing as well. In addition to Mrs. Wafa, I feel really thrilled working with these staff. They compete with me for helping patients. The standard, our level, we are well known at King Fahad Specialist Hospital by following a high standard level of care, and that's what make us competitors to the other sleep lab center. We know that all private hospital, they do have sleep lab. Patients like to come to us. Even top VIP like to come to us because of our high standard of support and high standard of care. Because we don't look at the patient as sleep study and result of sleep study. We do look at them as a human. We address them as a human. We manage them as a whole, not as a single entity. And I have mentioned that Wafa mentioned that we are the first and only Ministry of Health sleep lab center in the Eastern Province. But any program does run into a challenge. So we have a challenge with the lack of having full-time sleep physician. Sleep service is a draining out for sleep physician, is not very attractive for physician. So it's very important to have our own, to manufacture actually our own Saudi sleep physician. I am a pulmonologist. I do have some experience with sleep by training with sleep related breathing disorder, but I'm not 12-month trained. So I'm not qualified for full sleep lab physician. I'm supporting the service, I'm directing the service mainly. So it's very important to look into that. We are running the service with a part-time sleep physician. Also, we are having the challenge of the service is depend on the night duty most of the time, and that not attractive for the Saudi sleep technician because of our contract, because of there is different things that also need to be addressed to have a solid sleep center. Sleep lab venue, especially with COVID-19, we found that it's very challenging to do in-house sleep study, and this is very important to do for certain kind of cases, especially the central sleep apnea. Other spectrum of sleep-related breathing disorder, we cannot do it in-house during the COVID-19 because of the risk of disseminating infection and because of it is a patient area. So this is make us think, this is the right venue or the right place to have the sleep center in? which is in B1, the neuroscience ward. So the opportunity for the sleep center, as I mentioned, that we are lacking the sleep physician, it's very important to open sleep scholarship for physician, to have our own sleep physician, to encourage our trainee to seek this career of sleep related breathing disorder, to have the training program for the technician, and also to utilize the telehealth, especially now. ANAT telehealth is encouraged by our Ministry of Health. So there is a big opportunity to utilize the ANAT platform to develop it for the venue of sleep services. And that also need good knowledge of, need good developer for this service with good knowledge about the health information technology. Sleep service is a source of income for healthcare industry. So if we run this very well and utilize it very well, we can go further steps and make it a service for source of income with good potential for expansion. The threat for our services, it's more than what I have listed here, but keeping the service running, this is an issue really. Why? Because this service depends on the equipment, not only the human. So we have the human and the equipment. It's not like running the clinic alone. Clinic, you have physician, you have a nurse, you can run a clinic. But the sleep service, it's like radiology. You need to have the equipment and the technician and the physician. So this is make it challenging, especially with the technology might wear off and might come to a stage of unupdatable, like what we have witnessed in 2017. And also, so that's what I have for this time, and I will open the floor further for Mr. Abdullah, to elaborate on the statistic and the outcome for our sleep center.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Abdullah Khadoom. Inshallah, I'll be talking to you about sleep disorders, more to the medical side of it. Yeah, only 62.
10 slides.
I'll try, inshallah, to be as fast as possible. We still have time, right?
Yes.
Okay, so my content will be talking mainly about some introduction about sleep and sleep disorder breathing as diagnosing and treating sleep disorder in the sleep lab. As well as we'll have, inshallah, some case studies and services provided in our sleep lab. And at the end, if we have time, we'll talk about other disorders that are treated in the sleep lab. As an introduction, the sleep is defined as a state of decrease of awareness, environmental stimuli that is usually distinguished from other states such as coma by relatively rapid reversibility by the presence of some hormones such as the hypercortisone in the morning and the suprachiasmatic nucleus, which is our brainstem responsible about our circadian rhythm. Sleep is a universal behavior. It's also an essential component for good health and optimal cognitive function. And usually, as a human being, we need about 6 to 8 hours of sleep to avoid having sleep deprivation or loss of sleep. Okay, function of sleep, restoration and recovery, energy conservation, memory consolidation by sleeping in the REM stage, and discharge of emotions such as stress and anxiety, which actually correlates some psychiatric disorders to the loss of sleep and sleep deprivation. Thermoregulation, as we know, as we sleep, our temperature goes down. Hemostasis, homeostasis for our cells and tissues. And finally, maintenance of immune system by releasing the anti-inflammatory cytokines and other hormones such as the melatonin that is known to be the master regulator for our cell death. Okay, sleep stages, just briefly. 4 stages of sleep. Stage 1, which is known to be the light sleep, which lasts about 5 to 10 minutes and forms about 10% of our sleep. Then the stage 2, which is where we get unconscious and will be hard to be awakened easily, and heart rate will start to begin to drop and last about 20 minutes and forms the biggest portion of our sleep, about 50%. And stage 3, which is a transition from light to deep sleep. Usually we see the delta waves, and it is responsible about physical restoration of our body. This is one of the problems why sleep apnea patients usually have, they're fatigued and they're exhausted in the morning because they have problems reaching this stage because of frequent arousal during the night. Finally, the rapid eye movement, where the dream happens, and we call it the paradoxical, because the brain will be most active, almost similar to a awake person, but the muscle will be completely paralyzed under a state of atonia. And it is responsible about cognitive and learning, which explain the symptoms of memory loss and learning problems with patients who have sleep apnea, because again, they have problem reaching this stage of life because of frequent arousals. Okay, here's the important topic, sleep disorders. It is defined as any unusual event that happens during the night that will interrupt the sleep. And usually it is either a quality, quantity, or timing of sleep that cause interference with the person normal physical, mental, or even emotional function. When we usually talk about sleep disorder, we always think about sleep apnea. However, it is interesting to mention that there are more than 84 sleep disorders, and most of these disorders are, about 80% of them are diagnosed in the sleep lab, and the rest of them usually are treated in the sleep clinic with medication. 10 major groups of sleep. Most importantly is the insomnia, hypersomnia, narcolepsy, and breathing-related sleep disorders, including sleep apnea. And it is actually interesting to mention that some of these sleep disorders have a high prevalence, almost close to sleep apnea, which makes them as important as the other sleep disorders, such as the insomnia, which has a prevalence of 20 to 40% of population, which means that 20 to 40% of people will complain about insomnia at a period of their life. And this will be acute insomnia. If it is not treated on time, it will turn into chronic insomnia, which will complicate the treatment even, will make it even more complicated. Okay, breathing-related sleep disorder. The term means that disorder that caused by breathing during sleep, and it could be an obstructive sleep apnea, central or mixed, which has both have almost the same etiology, chronic habitual snoring and upper airway resistance, and hyperventilation syndrome, mainly seen as obesity hyperventilation and hyperventilation related to pulmonary diseases. Okay, so the most common breathing-related sleep disorder is the obstructive sleep apnea, seen actually with a prevalence of 24% in men, and this is a worldwide number, and almost 9% in females. And defined as the complete cessation or actually complete for apnea and partial for hypopnea, reduction in the airflow, breathing through the upper airway. Usually this is associated with snoring, which has the same etiology, caused by almost collapse of the upper airway with a high resistance for the airflow and rapid vibration. Okay, so to better understand how the sleep apnea occurs, considering this is an inhalation, considering this is an inhalation and exhalation, the airway will be obstructing, okay, and then the thoracic effort and abdominal effort will continue to happen. And this is what distinguishes obstructive sleep apnea from the central sleep apnea. At the end of event, usually there is an arousal, which explains again why the patient will be exhausted in the morning, because they have problems reaching the deep sleep and the REM sleep. At the end, there is a significant oxygen reduction, which mainly causes the comorbidities and other diseases. Usually the reduction is more than 3%, and in this case it went down from 97 to 86, which is almost at 10%. As I mentioned before, the prevalence of OSA is 20% in male population and 9% in female population. Comparing the sleep apnea with the asthma, which is widely seen, the asthma will be at a rate of 4% in population, and again, this is almost worldwide numbers. And then the percentage of population with sleep apnea is with an average of 17 to 18% combining both males and females. And even with that, it has been estimated that almost 82% of men and 93% of women are with moderate to severe obstructive sleep apnea remains undiagnosed. And to be honest, this is probably a part of, there's a lack of awareness in patients and even lack of discussion in the primary care physician offices about this problem. Okay, pathophysiology. As we sleep, the air goes through the nasal cavity to the upper airway, passing the soft palate, base of the tongue, alveolar tonsils, and genoglossus. With sleep apnea patients, there will be a collapse in these muscles, causing partial or complete reduction in this area. Again, the pathophysiology. So once the patient sleeps, they usually lose the neuromuscular compensation driven by the intropharyngeal negative pressure and the intrathoracic pressure. This will lead to a decrease in pharyngeal muscle activity, and a result of this, the airway will be collapsing, causing an apnea. The apnea will cause hypoxia and hypercapnia, causing oxidative stress. Then the brain will sense this and cause the ventilatory effort to be increased, causing an arousal from sleep. Then the pharyngeal muscle will be activated, and then the airway will open. And then again, the brain will cause a hyperventilation to correct the hypoxia and hypercapnia, and this cycle will happen again through another sleep onset, and it goes on and on. And as we say, sleep apnea or one event and pull another event. Okay, some consequences related to sleep apnea. First, related to excessive daytime sleepiness. like Dr. Manal mentioned, increased motor vehicle crashes. According to American Academy of Sleep Medicine, a study that was done, it showed that patients with sleep apnea are at 2.5 higher risk to have motor vehicle accidents on the road. And of course, this is because of excessive daytime sleepiness and loss of concentration while driving. Increased work-related accidents due to poor job performance, again due to excessive daytime sleepiness, depression, family discord, and decreased quality of life due to decreased daily activities. Some other consequences related to sleep apnea, which is considered the most serious consequences, is the cardiopulmonary consequences. So once the patient upper airway collapse and we get obstructive sleep apnea, they will be arousing, and this will cause, of course, a hypoxia. And a number of studies have shown that patients with sleep apnea have a high level of sympathetic nerve traffic due to and this increased sympathetic activation will cause like hypertension and some other diseases, and will cause a vasoconstriction and endothelial dysfunction. Another theory about this says that due to the unsuccessful forced inhalation, which changed the intrathoracic pressure frequently during the night, this could, over time, cause damage to the heart cells at night. Okay, hypertension. According to a number of studies, they found out that sleep apnea patients have a high level of angiotensin, the peptide hormone that causes vasoconstriction, and the angiotensin by itself will increase the aldosterone, which is responsible about retaining sodium in the kidneys, causing secondary hypertension. And according to a study that was done in Brazil on a cohort study of 125 patients, they found out that 64% of secondary hypertension was caused by sleep apnea. And they found out that 33% of OSA patients usually have hypertension, and vice versa. 33% of hypertension usually have obstructive sleep apnea, which is a huge link between the two diseases. Okay, we talked about the muscle activation, the muscle nerve sympathetic activation, and to better understand it, once we have a sleep apnea, a reduction in the flow or complete cessation for the flow, the oxygen saturation will be dropping, causing the muscle nerve sympathetic activity to be raised, which correlates with each apnea. And with every increase in the sympathetic nerve activity, there was a slight increase in the blood pressure. This repetitive increase and decrease in the blood pressure caused hypertension. Other consequences related to cancer. A study that was done in New York City in Ontario Academic Hospital, they showed as an association between sleep and malignant tumor, for some reason seen as breast cancers. The etiology is still unknown. However, it is believed that it's caused by low production of pro-inflammatory cytokines and suppression of the melatonin, which is have shown to be inhibitor for cancer growth. Another theory says that the hypoxia by itself caused immune suppression with oxidative stress and decrease in the oxygen level, which by itself caused necrosis for the cells and tissues and increase the angiogenesis, which is forming new blood vessels. This by itself caused a change in the DNA damage, or increase in the DNA damage. And the study showed that the increased risk was actually for obstructive sleep apnea was almost 15% which is a huge and big number for the association between cancer and sleep apnea. However, with severe nocturnal hypoxemia, this was associated with a higher risk, being 30%. This study was published in the American Journal of Respiratory and Critical Care Medicine, number 6414. Okay, diabetes. So sleep apnea patients have higher fasting insulin upon awakening. And this was actually found to be due to the increase, again, the same reason, the increase in the sympathetic nervous system, which increased the epinephrine and norepinephrine and caused increase in the catecholamine, which increased the hepatic glucose, as well as increase the insulin sensitivity and increase the beta cell death in the pancreas. Also, another study that was done in Nepal found an association between the plasma insulin and insulin resistance with the leptin hormone, the adipose tissue hormone that suppresses hunger and responsible about obesity, and was causing actually insulin resistance to the body. Financially wise, another study that was done by the American Academy of Sleep Medicine found out that, and this is done on the American population, by the way, treating all the obstructive sleep apnea patient could actually save $100 billion. This number came from the fact that with today's patient, where there are 80% of patients remain undiagnosed, with a cost of 162 billion, and future, where no OSA patients are undiagnosed, was with a total of $61 billion. Now, this cost with the undiagnosed patient came from other diseases, treating other diseases such as hypertension and coronary heart disease, and other comorbidities that were caused by the sleep apnea. As well as the motor vehicle accidents being with 26 billion loss, and the work accidents due to hypersomnia and excessive daytime sleepiness. Risk factors, I'm gonna just skip this part because it was mentioned by Dr. Manal. And as she mentioned, the obesity is the biggest risk factor for sleep apnea, as well as the abnormalities of the upper airway. Just some examples about upper airway who are at high risk for sleep apnea. Septal deviation, which causes the nasal resistance. Tonsillar hypertrophy, especially with grade 3 and 4. And large adenoids with lateral narrowing. Tongue size and macroglossia, which will help the tongue to relax more to the back of the throat, closing the airway. And retronalia, that usually seen in pediatric with cleft palate or other disorders such as Bayer-Robin syndrome, or seen sometimes after oral tumor removal. Upper airway size in OSA usually seen with obese patients, as we see here, like a crowded upper airway compared to normal individuals. And rib cage retractions seen in children, indicating increase the force and increase the breathing in the chest and the abdominal trying to catch breath. Okay, signs and symptoms for sleep apnea. Nocturnal symptoms during sleep apnea, and usually this is reported by other people, usually by spouses or other people in the house. Loud snoring, choking during sleep, So they will be reporting some like fighting for breath, as well as cessation of breath apnea witnessed by others, abnormal motor activity due to frequent arousals, gastroesophageal reflux disease, nocturnal enuresis, mostly seen in children, insomnia reported in some patients, and nocturnal sweating because of lack of oxygen at night. Daytime symptoms usually reported by the patient himself. The most important one is excessive daytime sleepiness. As we mentioned before, these patients would have frequent arousals causing them to, or preventing them from reaching deep sleep and REM sleep. As a result of this, they will be exhausted in the morning. Forgetfulness and memory issues due to lack of REM sleep. Personal changes, decreased libido and impotence in men causing infertility. Dryness of the mouth and awakening, because these patients will be trying to breathe out of their mouth to try to compensate for breathing. Morning headaches due to oxygen desaturation. And finally, hyperactivity and attention deficit in children. What are the treatments for obstructive sleep apnea? Three main treatments, behavioral, and usually is used for patients with mild sleep apnea, mainly weight loss, positional therapy to avoid supine position, and avoidance of some products, such as tobacco, alcohol, or certain medication that cause sleep apnea, such as benzodiazepines. The second treatment, which is the most effective treatment, is mechanical. That could be positive airway pressure with a high success rate of 70 to 100%. Oral appliance, which however, it have rate 60% the and positive airway pressure. First treatment line for pediatric, because it's hard to put pediatric on CPAP or BiPAP, and so the first line of treatment is TNA. The other surgical could be UPP, which is uvulopalatopharyngoplasty. However, these muscles still is the most effective treatment for obstructive sleep apnea syndrome. It works by increasing the lateral dimensions of the upper airway and thins the lateral pharyngeal wall and maintain the patency of the upper airway open during sleep. This pressure is actually different from one patient to another, and this is why we do a titration study, which means finding the upper patient to sleep. The positive airway pressure could be like what was mentioned before, continuous positive airway pressure, the CPAP. Bilevel positive airway pressure usually is recommended for pulmonary patients such as COPD to decrease the effort of breathing. BiPAP ST for the patient with central sleep apnea and more complicated patients. Self-adjusting positive airway pressure, the auto CPAP. Right now, we do use it for the home titration to, and we'll mention this shortly. Okay, this is a case review from our hospital, a patient that was referred by our pulmonologist, Dr. Manal. The patient is 50 years old, male, heavy smoker, 1.5 pack a day, with history of diabetes type 2, hypertension, COPD, with symptoms of loud snoring reported by his wife, shocking sensation, morning headaches, and daytime sleepiness and fatigue, and progressive weight loss. I remember him telling me that he gained about 20 kg in only like 4 months. On physical review, his heart rate is 92, blood pressure was 138/96, and saturation was 95. Chest is clear with lower left pitting edema, and he was later referred to a cardiologist. With upper airway Mulambati 2 to 3, and questionable depression. We performed a split night sleep study on him, which means that we did the diagnostic and the treatment studies in the same night. In the diagnostic portion, very short sleep latency. Patient was actually asleep during the hookup, indicating that the patient had excessive daytime sleepiness. Minimum SpO2, which is the oxygen nadir, was 62%. Apnea-hypopnea index, which is the number of events, respiratory events per hour, was very severe at 95 events per hour, considering that anything above 30 is severe. And the longest apnea was recorded for this patient was 58 seconds, which is a long time for apnea. And by the way, sometimes we see apneas up to 2 minutes. Sleep stages. He did not have any deep sleep or even REM sleep. He did have 33% of stage 1 and 67 stage 2, and of course this is related to arousals, as the arousal index correlates with the apnea-hypopnea index at 84 arousals per hour. On the sleep study, it was clear that the patient did have so many events, obstructive events. However, these events were with increased thoracic and abdominal effort, which means that the patient had clear obstructive sleep apnea. Almost each of these sleep apnea were followed by an arousal, which explained the fact why the patient did not have any REM or any delta sleep. And then significant desaturation, in this case where the error is, he went down from 92 to 72%. And variation in heart rate due to sleep apnea. Another slide at 4 minutes that's showing the same thing. And this window is 10 minutes window that shows like how many, shows that the frequency of having the obstructive sleep apnea and the arousals after each apnea. On the titration portion, sleep stages were almost 9% for stage 1, 56% for stage 2, 7% for stage 3. Now started to see stage 3 and REM. And REM was 28%, which means a favorable response to the CPAP therapy. So pressure was titrated from, and of course we use a BiPAP machine because he was a COPD patient. Pressure was titrated from 8/4 to 19/12, which was the optimal pressure, with a minimum saturation of 89%, which is a huge difference from the baseline. On the treatment portion, we have a nice flow with no events, and the oxygen remained at 90%, and as I said, the nadir was 89%. And we see the heart rate was more stable and no arousals, or actually with the minimum arousal at night. And finally, we got him on REM sleep, and this is where like the technologists feel happy when they see REM sleep during the titration. Okay. Central sleep apnea, which is a decreased drive to breathe and loss of the CO2 drive to breathe. And I remember once I was told that the most difficult thing in sleep medicine is to explain how the central sleep apnea happens. The etiology is still unknown. However, it is caused by the brain stem complex that fails to give signal to inhale, causing the individual to have sleep apnea and to miss effort. The difference between the obstructive sleep apnea and the central sleep apnea that there is no efforts in the chest or abdominal. So there is no signal coming from the brain to the chest and abdomen for the patient to breathe. Versus the obstructive sleep apnea, there is a signal, however, there is an obstruction in the upper airway. It is believed that it is caused by hyperventilation and again caused by other diseases causing hyperventilation, which will cause hypocapnia, causing the brain to generate a central sleep apnea, which will change the saturation and the CO2 level and cause an arousal. Usually the central sleep apnea is mainly seen in older adults above 65 because they will have comorbidities such as congestive heart failure, and also seen in children and infants who are born prematurely. And the diseases associated with the central sleep apnea could be brainstem abnormalities such as Arnold-Chiari malformation, could be neurogenetic conditions such as Prader-Willi syndrome, and we have been actually seeing so many cases in our sleep lab with the Prader-Willi syndrome. Prematurity, heart failure, congestive heart failure, and stroke. So this is how the etiology happened. There is a loss of birth that was associated with loss of efforts in the chest cavity and abdomen. This, of course, will be associated with significant oxygen desaturation. Just a quick case review. This is a newborn, 25 days old, born at 38 weeks, that was referred by a pediatric pulmonologist. The baby was born at normal vaginal birth, and he has a normal weight and height. Symptoms reported by mother: apnea ipsit and frequent awakening. Total sleep time is less than normal, and with this in this age, the total sleep time should be about 18 to 22 hours a day. Unfortunately, we don't have physical exam on him. Blood gas was performed outside the hospital. We don't have records on. On performing the sleep study, it was seen that he has very severe sleep apnea, specifically central sleep apnea. And of course, the scoring guidelines for the pediatric is completely different. However, in this case, he did have significant oxygen desaturation with each apnea. This is the central sleep apnea. This is the desaturation. On a 4 minutes window, it was clear that he did have very severe sleep apnea. Almost after 4th or 5th breath, he was stopping breathing as a central sleep apnea. Some of these apneas were followed by arousals. Okay. So what are the services provided in our sleep lab? First of all, we do two kinds of sleep studies. One is called in-lab sleep studies, where the patient will be sleeping in the sleep lab, and where we can do the baseline MPSG, which is the diagnostic sleep study. PAP titration using CPAP, BiPAP, BiPAP-ST based on the patient needs, or split night study, which means that we will split the night into a diagnostic and titration sleep study. During the study, we actually monitor the brain waves, eye movements, muscle activity, and legs, ECG, heart rate, and respiratory rate for presence or absence of respiration. This is one of our rooms, and we try our best to make it look homey, just to reduce the stress and the anxiety, just make it look different than the other rooms in the hospital. The other kind of sleep studies we do is the home sleep studies, where the patient will be taking a small device home and will be comfortably doing the sleep study at home. However, it gives us less channels, but it gives us the important information required to diagnose sleep apnea and hypoxemia. After the home sleep study, the patient will be given an auto CPAP for a home auto CPAP titration, usually done for 10 days. The machine has a chip that will be downloaded, and a report will be generated once the machine is brought back. This report will give us the compliance rate, will give us the apnea-hypopnea index while using the machine, will give us the pressure, which is the optimal pressure, and finally will give us a leak, indicating sometimes the more education for mask fitting. This is our request form for sleep studies, usually filled out by physicians, and what they have to do is just to put the name, the medical record number, some history about the medical and surgical on the patient, just to better understand the situation of the patient, determining the severity of the patient or the need to do an in-lab sleep study. I highly encourage filling out the stop bank questionnaire, just to gives us an idea about the severity of sleep apnea and how urgent the sleep study should be done. And I believe this form will be available for everybody. We'll try our best to put it on the portal soon, inshallah. Just briefly and very quickly, mention other sleep disorders are treated at our sleep lab. Some of them are treated at sleep clinic. We have the narcolepsy, which is the sudden attack of sleep, and hypersomnia, disorder of excessive daytime sleepiness. Usually we do an MSLT study, the multiple sleep latency test, done during the daytime to evaluate the level of hypersomnia or presence of narcolepsy. The periodic leg movements disorder, which is a repetitive movement of legs, sometimes caused by iron deficiency, anemia, or other disorders such as Parkinson's disease or other etiology. Insomnia, usually treated at the sleep clinic with some medication. However, patient might have sleep apnea, just sleep study to rule out sleep apnea as a cause for the insomnia. Parasomnias, which is unusual physical event that occur during the night, could be a confusional arousal where the patient will wake up and not knowing where they are and will be disoriented. Sleepwalking, sleep terrors for pediatrics, and nightmares for adults. Okay, circadian rhythm disorders, which is usually again treated in sleep clinic, such as jet lag syndrome for people who travel on the other side of the world, shift work sleep disorders, and I think we all at one point complain about this. Delayed sleep phase syndrome, which is seen mostly in teenagers who tend to go to bed a little later during the night. And advanced sleep phase syndrome for elderly patients. And finally, the non-24-hour sleep-wake syndrome for patients who don't have a biological clock or certain time to go to bed. Bruxism, diagnosed, which is the teeth grinding, diagnosed in the sleep lab and sometimes treated by dentists by oral appliances. Hypoventilation, that occurs because of increased the load and increased the upper airway dysfunction. Obesity, as seen as obesity, hyperventilation, lung disease, and chest wall stiffness, usually treated with BiPAP machine. Finally, I want to thank our amazing sleep team that has been working very hard in promoting our sleep services. Our medical team led by Dr. Amal Hazmi, our sleep director, and clinical team led by Wafa Malibari, our department manager. And with this impressive picture, I come to the end of my presentation. Thank you so much for listening.
We learn.
Yeah?
Coast.
Thank you all for your attendance. By this, we're closing this our day of celebration of the Sleep Lab. Thank you all for attendance and our participants on the online YouTube streaming. I hope we get some useful information, and we're open to any further needed information and communication.
Thank you all. Thank you, Dr. Ramadan, for your usual support, our director of Sleep Lab. Thank you, Sleep Lab team. Thank you, Mr. Abdullah. Thank you, Lami, and the team of Respiratory, our supervisor, Ms. Samah Al-Saad. And I can remember our colleague, Ms. Haya Ben Ali. She had a lot of effort during our organization of Sleep Lab. Thank you all, and wish you all the best. Thank you.